I'm live.
Good morning, everyone. Welcome to Cardiology Rounds. Today we have two speakers. The topic is taking diabetes to heart, the practical approach of using new diabetic agents for patients with cardiovascular disease. This morning, our two guests are Dr. Peter Liu, who we all know well. He's our Chief Scientific Officer and VP of Research at the Heart Institute, and Dr. Amel Arnaout, an assistant professor in the Faculty of Medicine in the Division of Endocrinology. We all know her at the Heart Institute as she's the clinical director of our diabetes program. So I'd like to welcome both our speakers today, and we look forward to their presentation on diabetes, the management in patients with heart disease, and discussing some cases at the end of the presentation to talk about how we integrate new therapies in patients with cardiac disease. So welcome to both of you, and we look forward to your presentation this morning.
Well, thank you very much, Ellie, and on behalf of Dr. Amel Arnaout and myself, I'd like to welcome everybody for the morning rounds, and Happy New Year's to everyone. Because there have been really a lot of recent developments in the management of patients with diabetes and patients with cardiovascular complications, we thought this is actually a great opportunity for us to kind of bring folks up to date and entertain discussions. And I'll just do a brief introduction. I'm just the warm-up act, for the real star of the show. That's Dr. Amel Arnaout, and so really appreciate everybody's indulgence. Let me see what is the best way for me to advance the slides. Okay. Okay, let me just try this again.
You should be able to now.
Okay, great. Okay, so let me see if I can do this. Okay, here we go. Thank you. Yeah, and so just in terms of the objectives of the session, let me just, okay, here we go. Yeah, ooh, yeah, objectives session. So it's really actually to discuss the new, impact of the new anti-glycemic agents and update recent guidelines on diabetes management. And I'll talk about in terms of impact on cardiovascular outcomes and the potential implications for our patients. And the following are our conflict of interest. And just a couple very typical cases, which we'll cover at the end of the presentation as well. And the first case is a 49-year-old female with diabetes, but she comes in with acute coronary syndrome and has a very significant advanced coronary artery disease. And the second case is a patient with diabetes as well, but also has heart failure and presented with decompensated heart failure. And the question is beyond our usual management of these cardiovascular conditions, since diabetes is such a major underlying factor in their disease conditions, can we actually treat the diabetes better to improve their cardiovascular outcomes? And some of these considerations have come about because of the fact that, let me see, yeah. The fact that the diabetes, in fact, is a major cardiovascular risk factor, and it affects really the all the organs in the body, but particularly in terms of the vasculature, in advancing atherosclerosis, heart, in terms of cardiac function, as well as renal function. And so we really end up with a lot of patients with advanced disease in our care. In fact, about a third of our patients with acute coronary syndrome or heart failure have diabetes that's not well managed. So the question is, are there things that we can actually do in this type of setting? Let me see how I can advance this. And okay, oh, here we go. And the other challenges that we have had for quite some time, and hence for cardiologists, this was an area of conundrum, is the fact that the agents that actually helps in terms of glycemic control, whether that's related to sulfonylureas and in terms of DPP-4 inhibitors, or even insulin, which we're celebrating a 100-year anniversary this year really has had not any impact on cardiovascular outcomes for the patients. And even though they can actually control the elevated the blood sugar, lower the hemoglobin A1C, but no impact whatsoever in terms of outcomes. And this is a very large cohort recently published of 17,000 patients, and you can see that whether it's related to mortality, related to cardiovascular complications, or even hypoglycemia, there is really a steady deterioration in patients with diabetes. And so it's really now that we have new agents that can really not only confer glycemic control, but also good cardiovascular outcomes. And this is really a very exciting time in our journey. And so we would like to discuss the opportunities of these new agents and the application of these for our patients. And if I can then turn the podium over to Dr. Arnaout, who will actually take us to the key components of the presentation.
That's great. Thank you very much, Peter. So I'm hoping that I have taken back control. Yes, I have. Okay, that's good. Again, I just want to thank everybody for the opportunity to be here to talk about this interplay between cardiology and diabetes, which is so much a part of what we do. I wanted to highlight some of the new approaches that I have taken, and I hope I can share with all of you so that you can also take to take care of our patients that have both diabetes and heart disease, and in some cases don't even have diabetes, but would benefit from some of these diabetes therapies. Okay. So this is not new data. This is the prevalence of diabetes by province and territory in Canada. I was looking at this yesterday, and it kind of looks like the inverse of the COVID-19 testing rate. It certainly is a lot higher in terms of diabetes prevalence compared to when this data was collected. We're close to 10% now across the nation. And even though that seems like a big jump, and it is considered a booming epidemic of diabetes in the country, this is an underestimate in terms of the prevalence of diabetes in our cardiac population. So depending on the cohort that you look at, you could see anywhere from 30 to up to 50% of patients who are inpatients or presenting for procedures or cardiac surgery who have diabetes and pre-diabetes. So when we talk about cardiovascular disease and diabetes, for the most part, we are referring to type 2 diabetes, which is by definition the form of diabetes that presents as a result of insulin resistance, and over time can evolve into a situation where there is insulin deficiency and a secretory defect of the pancreas, but it is clearly distinct from type 1 diabetes in terms of etiology. It is not an autoimmune etiology. And although individuals with type 1 diabetes do also get cardiovascular disease, and it's important for us to screen and manage those, the therapies that we use to manage type 1 diabetes are very different. And in some cases, with what we're going to be referring to today, it will be absolutely contraindicated, in particular agents like SGLT2 inhibitors, where there is a high risk of complications if it is used in individuals with type 1 diabetes. I bring this up only because it is harder and harder these days to tell the difference between type 1 and type 2 diabetes, as our type 1 diabetes patients do tend to get older, and they also tend to develop a lot of the comorbidities that we see with type 2 diabetes. So it is important to ask those few extra questions to decide whether someone has type 1 or type 2. So the pathophysiology of hyperglycemia in type 2 diabetes is multifocal. It's a result of various different systems within our body that promote elevated plasma glucose, elevated production of glucose by various organs, and a defect in insulin function. And our various agents that we use to manage diabetes target those specific area. And until very recently, we had a limited number that mostly worked mostly at the pancreas in terms of trying to promote extra insulin secretion from the pancreas, and also at the liver in terms of trying to diminish hepatic gluconeogenesis, improve insulin sensitivity at the liver, and as well as at the skeletal muscle. More recently, these newer diabetes agents are targeting kidney in terms of glucose secretion by the kidneys, which is helpful in terms of lowering plasma glucose, but also does have important role to play in terms of the hemodynamics of the cardiovascular system. And the second big area is in the gut hormone system or the incretin system, which work to promote gut neurohormonal systems to enhance insulin secretion, appetite regulation, and gastric output. So we know that an unhealthy lifestyle does promote excess weight gain, obesity. Obesity is tied very much into diabetes as well. Diabetes does have a huge genetic component as well, particularly type 2 diabetes. And all of these environmental and genetic phenomenon will lead to the excessive cardiovascular risk that we do see. And it happens over time, and there are various vascular factors that are at play here, and it's not merely glucose. And this is important to note because, again, our understanding of how we target the cardiovascular system in terms of the abnormalities that we see in diabetes is not purely based on the effects of the plasma glucose. So the other things that are well described in terms of what can lead to cardiovascular demise, certainly free fatty acid production, which can lead to elevated oxidative stress. Insulin resistance on its own has been associated with not just weight gain, but also impairment of cellular function. And all of this can lead to inflammation, thrombosis, vasoconstriction, and other vascular associated conditions like hypertension, dyslipidemia, and that also works together to increase cardiovascular disease. So now shifting gears in terms of how we manage diabetes, I think most of us are quite familiar with, the targets of blood glucose and A1C, and the guidelines really are just there to help intervene at various points in someone's diabetes history to be more aggressive or less aggressive and to introduce new forms of therapy. To that end, the 2020 update in the pharmacological guidelines for the management of type 2 diabetes was released a few months ago, and there's some key changes that I'm going to highlight. So the first thing that I'm going to mention is that the first-line therapy for metformin has not changed, and there is a multitude of safety data associated with use of metformin, our long history of use, and some long-term outcome data that perhaps are not as impressive as some of the newer agents with hard outcomes like CVOT. However, in terms of sort of still improvement with microvascular disease, long-term overall health, long-term prevention of things like weight gain and cancer, metformin is still considered first line, and it's an easy enough medication to take, easily affordable by majority of patients, that it really still should stay in that place. However, if metformin on its own is not enough, and that may be a situation where you're starting off with an A1C that is very elevated, greater than 1.5% above target, or if despite therapy with metformin for 3 months that the A1C target is not attained, then it's the next step will be to advance therapy with a second-line agent. For most people, the target A1C is still less than 7%. And, for most people, if you're dealing with someone who's very symptomatic at presentation or in an acutely ill or hospitalized patient, the first line would be to start insulin plus or minus metformin. So with regards to second line agents, we have various classes that are available. So the top two columns there, rows there are the GLP-1 receptor agonists and SGLT2 inhibitors. There's various agents within each class, and they are safe. They reduce blood sugar. They both tend to reduce weight. They have significant A1C lowering, but they do also come with their own set of side effects and contraindications. To the bottom half of the table, you'll see some of the more traditional or older agents that has been used in the past. Some of them that are not used very much anymore, including TZDs, which have fallen out of favor because of their cardiovascular side effects, and also sulfonylureas, which, although are very effective, really have a high risk of hypoglycemia, weight gain, and lack of long-term cardiovascular outcome data. So I know that Peter is going to go over some specific trials, so I'm going to leave that to him, but I just wanted to kind of put on this table, which summarizes, again, these are all studies that's happened within the last 5 years with GLP-1 receptor agonists and SGLT2 inhibitors in high-risk cardiovascular populations, and looking at these agents in terms of major adverse cardiovascular outcomes. And as you can see, there are definitely positive effects on cardiovascular outcomes or a reduction in MACE for several agents within each class. And this translates into reduction in mortality, in non-fatal MI, non-fatal stroke. And then specifically for the SGLT2 inhibitors, we also have heart failure, reduction of heart failure data, and progression of CKD. So back to our sort of second line algorithm. So in the recent update, it now very specifically guides clinicians that if you have a patient with type 2 diabetes and have a history of cardiovascular disease or CKD or heart failure or have risk factors for cardiovascular disease, you really should be considering an SGLT2 inhibitor or GLP-1 receptor agonist above all other diabetes therapies that are available. And so this is a very, practical. It's very specific to type of patients that we should be including in this. And whether you choose one versus the other may depend a little bit on the features of the patient. Are you more concerned about the heart failure risk as opposed to really trying to get a huge reduction in A1C and weight? So the differences between the two agents really come down to those individual patient characteristics that may make you favor one or the other. But the other positive thing that I will highlight here is that you can use both in combination, and you also can use these agents in combination with almost everything else that we have available for diabetes. So it's a very easy add-on medication to use. On the right-hand side of the algorithm, you'll see that even if someone does not meet those very specific patient characteristics like clinical cardiovascular disease, the CKD, cardiovascular risk factors, you still may favor these newer agents over the older traditional sulfonylureas and TZDs because of the more favorable side effect profile, the reduction in weight, and some primary prevention data that we have with specifically heart failure that you may choose to use those agents as opposed to some of the other ones. I'm going to kind of talk about GLP-1s because I think most people are quite comfortable starting a pill on somebody. But GLP-1 receptor agonists are injectable therapies, and they can present a challenge if patients are new to injections. But it is a very once you've done it a couple times, it actually is not that difficult because it's a pen system that the patient can obtain from the pharmacy. The pharmacists are really quite good about teaching how to use the pen, and there is a difference between an insulin pen and a GLP-1 pen. The titration scale on the GLP-1 pen is very straightforward. There's usually only 2 numbers on it, a low setting and a high setting. And I often prescribe these agents over the phone these days to patients. I describe how they should be using it in their abdomen, that they should start at the low dose for 4 weeks, and then escalate after 4 weeks if they have no side effects. Because it's once weekly, it is a very easy medication to take. However, sometimes people do ask, what if I miss a dose? And it is important to also be able to answer that. You know, if someone misses a dose, they can make up for it as soon as they remember, up to 5 days after their intended day, and then they can go back to the regular cycle of whatever day that they choose per week that they want to use it. I will also note that there is an oral version of this particular GLP-1 semaglutide that is available. The injectable semaglutide is covered on ODB for everybody over the age of 65, whereas the oral option is not yet covered. So even though there is a potentially easier prescription that you can write for oral, you need to be cautious that it is not covered yet. And there are some specific way that you have to take the oral medication. It's not to be combined with other medications. It needs to be taken first thing in the morning on an empty stomach with just a very little bit of water in order for it to be effective. As for SGLT2 inhibitors, again, these are pills that can be prescribed, usually taken in the morning, once a day. We have 3 options available: empagliflozin, available in 10 and 25 milligram tablets; canagliflozin, available in 100 and 300 milligram tablets; and dapagliflozin, available in 5 and 10 milligram tablets. For the most part, it doesn't make a huge difference what dose you start the patient on. Often with EMPA, I will start the low dose because it really didn't show a big difference in cardiovascular outcomes between the 10 and the 25 milligrams. Whereas with DAPA, I may start with a higher dose at the 10 milligrams because that was the dose that was used in most studies. However, you know, with canagliflozin, I would just put a hint of caution. It tends to be a little bit more effective in terms of hemodynamic effects and lowering of blood pressure. So that particular SGLT2, I tend to start with 100 and then escalate the dose after I've had a chance to reassess their hemodynamic status. Now, people do worry about SGLT2 inhibitors because of the potential side effects. So I'm just going to go over the benefit and the side effects of the SGLT2 inhibitors and hopefully address some of those concerns. So for glucose control, it is quite effective, but it's not the most effective. So, you know, you're going to expect an A1C lowering of somewhere about 0.5%. So again, if you have someone who has an A1C that's at 12%, just starting an SGLT2 inhibitor is, number one, not going to get them to target. And number two, you're probably going to be getting a lot of side effects because the glucosuria that is associated with that very elevated A1C is going to be significant. So I would reserve use of SGLT2 inhibitors once you've been able to optimize glycemic control, ideally to an A1C of less than 9%, and then add it on as the next agent. When you do have a large amount of glucose going through the urinary tract, the concern is urinary tract infections and genital mycotic infections. These are, you know, depending on the patient, can be very problematic, particularly women who have a history of yeast infections. The rate can be as high as 10%. I would say that, you know, this is something that you have to caution patients about. I routinely list this as a potential side effect. However, I do also tell them that not everybody is going to experience this, and if they do experience an infection, it is easily treated the same standard way that we treat all infections. And generally, if an infection is treated and it goes away, it doesn't mean that that medication cannot be continued. It would only be in a situation where there's a recurrent infection that keeps coming back. Weight loss is another effect, although it's, again, not a huge amount of weight loss. For most people, we're talking about 4 or 5 pounds at most. Certainly not to the degree that you would see with a GLP-1 receptor agonist, which tends to have a greater weight loss effect. And you know, in that situation, I've really rarely had anybody complain that that the weight loss is a problem. However, you know, I would be cautious in a very lean individual who perhaps is younger, who perhaps you know, are on insulin, because there is this in-between category, type 1.5 diabetes, like we sometimes like to call, or LADA, latent autoimmune diabetes in adults, where patients don't exactly present like type 1 diabetes, but they're also not quite the same phenotype as type 2. And that's the type of patient that you would worry that you're going to have a higher risk of this euglycemic ketoacidosis, which has been reported with the use of SGLT2 inhibitors. So in that particular lean, younger patient who look like they may be more insulin dependent, you know, you have to use this with caution or not at all. And if you do that, then the rates of DKA actually are quite low. And I have to say, you know, I've had 3 major cases of DKA associated with use of these agents. I've been using them since they came on market. And one of the 3 was in sort of a LADA patient that was not diagnosed. And another one was someone who had, you know, significant surgery and did not stop the medication. And the third one was a fluke. But, you know, it certainly is not as high as what we worry about if it's used in the proper patients with the proper guidelines about stopping before surgery and not to use if someone is severely caloric restricting. So hypoglycemia risk is quite rare, as well as acute kidney injury risk. And this is something that I think is really important to note, because we now have good evidence that these agents are actually renal protective. So even in people who have reduced GFRs, and we have evidence down to GFRs of 20 to 25, that use of these particular agents can actually be nephroprotective. I think that it really pretends that there's really no necessarily a hard cutoff for their use for the sake of nephroprotection and even cardioprotection. However, for glycemic benefits, the lower the GFR, the less glucose loss you're going to see, and therefore you're not going to see a great improvement in glycemia in someone who has a lower GFR. And then some of the other sort of rare things that have happened with only one of the SGLT2 inhibitors, things like amputations and bony fractures. You know, again, it doesn't seem to be a class effect. It's been looked at in the other studies with other SGLT2 inhibitors, and there's been no reported increased risk. But I would just use with caution for that particular SGLT2 inhibitor in someone who has a prior history of peripheral vascular disease, active ulcer in the feet. You would want to be avoiding use of or starting this medication for that reason, for the increased amputation risk. So what about hospitalized patients? And this I really want to bring up because part of the incentive for doing rounds today is because we now do have approval for SGLT2 inhibitors, 2 of them, empagliflozin and dapagliflozin, on the formulary at the Heart Institute and at the Ottawa Hospital. This was between the Division of Endocrinology, Cardiology, and Nephrology to ask for these medications to be on the formulary so that we have that option to provide our patients the appropriate patients who would benefit from them. However, along with this being available, something being available doesn't mean it needs to be used all the time. We need to be cautious about the type of patients that we're using these agents in. It certainly is not a medication that you should be using in an acutely ill patient with hemodynamic instability, variable oral intake, because the risks of AKI is much higher in that situation. The risks of DKA is much higher in that situation. We know that when patients are acutely ill, their hyperglycemia gets worse. I hear all the time from my patients, they don't know how to manage my diabetes in hospital. Every time I go in, my sugars go crazy. And that's perhaps partly true, but also because, there is a lot of stress, cortisol response, illness, infection, surgery can all lead to hyperglycemia. Hyperglycemia can lead to then poor immune response, poor wound healing, which then increases the illness and increases the stress. So it does become this cycle, and management of hyperglycemia in the acute stage when there is infection and illness is best to be done by specialized teams, diabetes educator, nurse. We're lucky at the Heart Institute that we do have that, along with endocrinology or diabetes specialists to manage that. Because it can change day to day and usually requires insulin therapy. So I was fortunate to be part of a Canadian consensus on guidelines for use of SGLT2 inhibitors in hospitalized patients, stable hospitalized patients. And we published on this, and basically we wanted to really have that option available, but really also highlight the caution for use of these agents in hospital for patients who are really not indicated to start the class of medication. So the questions that should be asked before starting are, why was the patient admitted? What was the course in hospital? Are they clinically stable? If they're not, then you need to really hold off and it can be started post-discharge. What are the other medical issues? So is there a history of falls? Is there a lower GFR or fluctuating GFR or frailty? What other medications are also on board, and do they need to be adjusted? And in particular, diuretics. Now, diuretics are interesting because in stable heart failure patients who are on diuretics, I rarely have to adjust the diuretic dose when I start an SGLT2 inhibitor. However, in a hospitalized patient where those things can be much different, the fluid status can be very different, you do need to pay attention to whether you need to cut back on another diuretic agent in order to introduce a new medication that would work to also promote water loss. And then what are the indications? So, can it wait? So this is a very important question to ask, because if someone is just on an SGLT2 inhibitor for glycemic control, as I mentioned earlier, the glycemic benefit is minimal. And most patients in hospital were able to manage their glycemia through other means. However, if someone has a high cardiovascular risk, heart failure, post-MI, there may be some short-term benefits that we can see pretty immediately after initiation of these medications. And so for the right patient who are out of the immediate danger of hemodynamic instability, I do think that there is a role for these medications to be introduced early, prior to discharge, or just shortly after discharge. And then the follow-up assessments that you need to pay attention to, obviously renal function, but that needs to be also taken with a grain of salt, because we know that the renal function is going to change. It's like ACE inhibitors. You see like a 15% reduction in GFR within the first few weeks of starting this medication, but then it stabilizes and you do see that kind of the crossover of the GFR to now becoming more stable, and the decline is less at the 6 to 12 month mark. But, monitoring in someone who has fluctuating GFR or already impaired is not a bad idea. Blood pressure needs to be assessed, A1C, again, that's not super urgent. And, obviously looking for signs of DKA. And remember the type of DKA that you see with this type of medications is, termed euglycemic, where the glucose is not very elevated or only moderately elevated. For surgical patients, I am just going to mention that, the guidelines are to stop the medication 72 hours before all major surgeries, and to restart it after the surgery 3 to 5 days. For most people, if someone has had major weight loss surgery, then you would have to wait longer. So if we do start to use SGLT2 inhibitors in hospital, we need to assess blood pressure. We do not want to initiate it if the blood pressure is already soft, or if someone already has had genital urinary surgery and the risk of infection is higher. You don't want to use it in addition to other nephrotoxic medications that are being introduced at the same time, sepsis and radio contrast. And then, monitoring of the renal function. Generally, if you have the option to monitor while someone is in hospital, great. And you want to kind of really make sure that their GFR doesn't drop by greater than 30%, which would be an indication to stop the medication, and then monitoring blood pressure and fluid status. And I'm just going to end on this slide because this is practically what I hope that we can all do. Certainly not every individual with diabetes or heart failure will come across my clinic. I think it's important to think about in these patients with cardiovascular disease, if they're clinically stable, greater than 48 hours post-event, they're not, concerned for fluctuating renal function, and their GFR is appropriately above 30, which is the current Health Canada indication for SGLT2. Then you can consider initiating an SGLT2 inhibitor. And most cases, you can just add this on in addition to whatever else they are taking. If their A1C is already on the lower side, less than 8%, less than 7.5%, and they are on an agent that potentially can cause hypoglycemia like insulin, like a sulfonylurea, you may want to reduce the dose of the insulin or sulfonylurea, or stop the sulfonylurea in order to introduce the SGLT2 inhibitor. And then following up with reassessment of blood pressure and GFR within a couple of weeks in someone that there is concern of already low GFR, and then really counseling on appropriate sick day management in case someone gets symptoms of DKA, what to do in that situation, and appropriate follow-up as an outpatient. So this is what I would recommend as an algorithm for our patients at the Heart Institute. My hope is that with appropriate patient selection, we'll be able to start this en route out. So close to discharge, couple days before discharge, if we're able to initiate people on these cardioprotective medications, that would be ideal. The next step will be to get the GLP-1 on formulary, which it currently is not. So thank you very much, and I'm just going to have Dr. Liu take over.
Great, thanks so much. That's a wonderful overview of this dynamic area, and with a lot of practical insight. And we're very lucky to have our diabetic nurse team, Kim Toyman, and certainly Amel, in terms of looking after our complex cardiovascular patients with diabetes. I just want to really just highlight a few points for very simple-minded, cardiologists, the practical aspects, and particularly in terms of the cardiovascular outcomes of some of these agents. And so, as Amel mentioned earlier on that really very nicely put together table, that we do know that in terms of patients with cardiovascular disease, that the GLP-1 receptor agonist, whether it's liraglutide or semaglutide, or SGLT2 inhibitors, particularly like EMPA and DAPA, all have a benefit in terms of MACE reduction. But however, the type of MACE that is reduced is different, and this is where I think some of the tailoring of our patient treatment becomes useful to consider. And so the way I tend to think about this is that if you have a patient who dominantly has atherosclerotic complications and possible also renal abnormalities, the GLP-1 receptor agonists are your top choice for that patient in terms of both glycemic control and cardiovascular outcomes. So patient with coronary disease, intact ventricular function, this will be perfect. On the other hand, if the patient has heart failure and or renal dysfunction, then SGLT2 inhibitors or SGLT inhibitors, we'll see later why that's the case, will be helpful. And in fact, from a cardiologist's point of view, I quite often think that the SGLT2 inhibitors are heart failure renal agents that happens to lower blood sugar because they are not really necessarily your best glycemic control agents, as Amel mentioned earlier. And I just want to mention just a little bit in terms of the GLP-1 receptor agents, that it does actually have anti-inflammatory effect and antiplatelet function, many of the things that we're looking for in patients with atherosclerotic complications. And there are many studies looking at cardiovascular outcomes involving the GLP-1 agents, but the largest set of data really reside with liraglutide, and in the leader study, and Semaglutide in SUSTAIN in terms of injector form, Pioneer in terms of the oral form, as well as the REWIND study in terms of dulaglutide. And so just an example of the leader study was the liraglutide. This is really actually the first study that really looked at the cardiovascular outcomes in patients with pre-existing disease. And then liraglutide, which is the injectable GLP-1, was able to have 13% reduction in cardiovascular events. And a lot of this is driven by stroke and also cardiovascular mortality. So as Amel mentioned earlier, certainly the most popular GLP-1 agent at the present time in Canada and probably worldwide is the semaglutide. And because it actually comes in two forms, either injectable weekly, but there's actually a new one that's actually oral form, and that's already available in Canada. And certainly patients, will need to be covered at the present time with insurance in order to use this. But in the Pioneer study, which look at the oral semaglutide in terms of outcomes, you can see that in terms of the MACE, despite the fact that it's actually a relatively small study, shows 21% reduction in terms of combined MACE in cardiovascular patients. And in fact, it was highly significant in terms of reducing cardiovascular mortality as well, despite its small size. And the SGLT2 inhibitors, Amel has covered very nicely, so I won't belabor the point, except to point out that, in fact, SGLT2 inhibitors is useful not only for patients with diabetes. Of course, now we know that it's actually good for general patients with heart failure and renal dysfunction. And I just want to point out on a couple, so I'll skip this. Yeah, so certainly the most important study that opened everyone's eyes in terms of the SGLT2 in heart failure is the DAPA heart failure trial that came out last year. And so the important aspect to look at this trial is that half the patient had diabetes, but the other half did not. And these are HFrEF patients, so ejection fraction less than 40%. And the hazard ratio is 0.74, 26% reduction in mortality or hospitalization. And it's just absolutely, impressive. There are a few agents in heart failure come close to this, and you can see the absolute p-values. And then this is replicated practically to the same extent with the EMPEROR study involving empagliflozin in a slightly higher risk patient population, hazard ratio 0.75. You know, how close can you get when you have two completely different studies using two agents, but they're in the same class, and the results are practically identical. It's just uncanny how reproducible this is. And it's, again, same thing in the Emperor reduced study, whether you had diabetes or not, you had the same beneficial outcome. And so really, this underscores that, you know, this is really a heart failure renal protective agent with nicely glycemic control properties. And so you can see that when you actually put the two trials together, the DAPA and the Emperor, they're identical studies. In whether you have diabetes or not, no diabetes, identical outcome. And so this really underscores that whether you have diabetes or not, these agents are protective in heart failure. And I just want to kind of really bring another whole interesting angle to this, was the Soloist trial, which is a little different from the DAPA and EMPA studies. And this is with sotagliflozin, which is SGLT2 plus SGLT1 inhibition. This is actually a very small trial because it was terminated early for lack of funding. Yet, it's interesting from the point of view that this a lot of these patients had these agents started. These are patients with acute heart failure in hospital, started right in hospital. I think about a third of patient had these agents start in hospital. And the two is that it had both HFrEF and HFpEF patients. Very interesting. And you look at the result of that, you know, so this trial had to stop early. The hazard ratio of 0.67, highly, highly significant, even though this is a very small trial. And the differential between the two was observed, you know, right within 7 days of initiation. And by 28 days, it's already highly significant. It just shows you that this class of agent is perfect for heart failure. And don't be afraid of it. Even when you start in hospital, you get an even bigger bang for your buck. And the other aspect is the renal function aspect. And it's very important to look at this very carefully. And that is that you can see that when you actually, this is from the Emperor, when you have serial follow-up of the GFR, you can see that there is that reduction in the beginning, which could scare off, you know, sort of unwary, you know, attendings. And then you can see that the slope of decline becomes much more attenuated during follow-up, and this is sustained over time. And this is being seen also in the DAPA-CKD study. And it is, so I always say that these agents are like ACE inhibitors. You get the initial tempering of the renal function or a bit of a rise in creatinine, but overall, this is extremely protective over time. And this also has longer impact, longer-term impact in terms of renal failure requiring dialysis, and this is observed across all the SGLT2 trials. And don't forget that not only the SGLT2 inhibitors are so protective in terms of renal function, but the GLP1 agents are also protective, and the GLP1 agents, in fact, can go down even lower in terms of GFR. So these are the practical tips that I've learned. So this is a cardiologist, and this is probably not correct from Amel's point of view, but this is kind of I learned that the GLP1 agents are better in terms of reducing hemoglobin A1C, on the average 1.4%, and greater weight reduction. And versus SGLT2 is really actually much milder in terms of glycemic control. And this is dependent on renal function. You know, when renal function is not so good anymore, it's not so much of a glycosuric agent, but it still is protective. And the other important aspect that Mel mentioned earlier is that as cardiologists, we kind of worry, you know, oh, adding another agent, the patient might get hypoglycemia. That's not true at all. These agents, in fact, have very low risk of hypoglycemia, but it allows the ability for us to actually reduce agents like insulin or sulfonylurea, which are less cardioprotective, or in fact, they're not cardioprotective at all, and they are much more hypoglycemia inducing. So we really can improve the entire portfolio of approach to treat our patients with diabetes. And so in terms of just a couple words on the oral semaglutide, because it really adds flexibility of introduction of GLP-1 agents. So you now have a choice of the once weekly injection versus a daily oral dose. So some patient would prefer one form versus the other. So now you have flexibility. And that, as Amel mentioned earlier, the oral agent should be taken early in the morning on an empty stomach with half a glass of water, and then wait 30 minutes before breakfast. You know, I always ask patients, do this the first thing you wake up, you know, before you kind of get ready for the day and things like that. And then half an hour later, then you're totally free to do whatever. And these agents can be combined, as I mentioned, as Mel mentioned earlier, for better glycemic control. Some of my patients on these combination are now completely off insulin and have never felt better in their life. And the other aspect is that, as mentioned earlier, SGLT2 benefits in heart failure renal protection are independent of glycemic effect, you know, because you don't have to have diabetes to get exactly the same benefit. So keep in mind that GFR down to 20 and 40 still okay, even though, you know, there's no you know, major benefit on hemoglobin A1C at that level. And the other thing Mel mentioned earlier is the diuretic effect, but it turns out that the SGLT2 inhibitors may have transient diuretic effect on some patients. So this is not a consistent thing. And so you can, you know, sort of, if the patient is very dry, you should reduce their diuretic transiently, because I've been now caught many times now in which I got the patient to reduce their diuretic, which is a great, patient loves the agents, but then they end up with the heart failure because they were behind on their diuretic. So that diuretic may need to be reintroduced. And on these trials, in fact, there's no net impact on diuretic use in heart failure. And there may be transient reduction on GFR we mentioned earlier, just like ACE inhibitors. And no dose adjustment is needed. This is so easy for cardiologists. Just 10 milligrams of EMPA, 10 milligrams of DAPA, you know, and away you go. And remember that in terms of renal protection, according to the trials, for DAPA is down to GFR 30, for EMPA is down to GFR 20, and GLP-1 receptor agonist is down to 15. And so just in conclusion, then we really actually have these wonderful new classes of agents that turns the page for looking at our patients with diabetes. GLP-1 agents improve glycemic control, mediate weight loss, reduce atherosclerotic complications, and SGLT2 or SGLT inhibitors reduce heart failure and mortality and hospitalization, preserve renal function. Both agents are complementary, can be used together for better glycemic control, as well as, you know, improving quality of life, which we didn't talk about too much earlier. And so I thought maybe I'll just ask Amel to comment on, you know, for example, management of maybe one of these patients, and then we'll open up for Q&A, because I think this is very important for people to ask questions for Amel. So this is actually a real patient. Some of the folks around the table may remember this patient, and this is a patient I've referred to Amel, so she'll be seeing her soon. And so this is 49-year-old lady who's got diabetes for over 10 years. She was on glucoside and novorapid insulin prior to her admission. She presented with dyspnea and chest pain. Hemoglobin A1C was 10%. It's never actually well controlled for sure. And so she had a troponin bump. Ejection fraction is reasonably preserved, but the angio showed that she has a significant 3-vessel disease. She had a PCI to the RCA, but she had a residual CTO of the OAM and also LAD disease. And she was discussed at the combined rounds. Ultimately, she was decided to go forward with cabbage, and in fact, she just had her cabbage. And so she'll be, you know, sort of being followed up by Mel. So just maybe we can use this for Mel to comment on the management, and then we entertain questions.
So yeah, so my comment is definitely, I think there's definitely room to upgrade this woman's diabetes management. Glucoside, you know, novorapid. I mean, this woman clearly can be on both SGLT2 inhibitors and GLP-1 receptor agonists. It comes down to timing, to be honest. You know, if I had seen her before her cabbage and I knew she had imminent surgery, you know, knowing that we have to stop the SGLT2 before, I may have chosen to optimize a GLP-1 first. first, that has cardioprotective properties, but maybe won't need to be interrupted. She'll have a week before she goes into hospital or two, and then starting the SGLT2 inhibitor after she's recovered from her surgery. In a patient like this, I would be cautious of just starting an SGLT2 inhibitor without optimizing her insulin. I think the A1C being quite elevated, being only on NovoRapid, she needs a basal insulin as well. That would make the most sense, is to try to wean down the glycoside, wean down the NovoRapid, add on a basal insulin, add on one of these great cardioprotective other non-insulin therapies, and get her ready for surgery. I would want her A1C, if possible, her blood sugars, in the target of 7% going into surgery, because her risk of sternal wound infection is quite high with those kind of numbers.
Yeah, so that's absolutely, it's almost foresightful, So, yes, so that's fantastic. Maybe we can turn back to Ellie in terms of some Q&A, especially when we have Amel here.
So thank you to Peter and Amel. We do have a couple questions and only about 5 minutes left. So I know, Amel, you've talked a lot about appropriate GFR cut points for initiation of the drugs. I think on your last algorithm for hospitalized patients, the cut point was a GFR of 30 for canagliflozin and DAPA. And EMPA, and 45 for DAPA. Are those cut points equivalent in the outpatient population?
So no. So definitely, as you've seen, some of the studies really do for EMPA, gone down as low as 20, and DAPA as low as 25 for DAPA CKD trials, and shown effect. But in terms of the hospitalized patients, we chose a level of 30 for safety, knowing that in this acute population with potentially some hemodynamic instability, it gives you a bit of wiggle room to watch for a drop. But for outpatient population, you can potentially go, and I have gone lower.
So some of the other questions are, in patients going for coronary angiography, where they will be receiving dye load, should the SGLT2 inhibitors be held in advance for 48 hours?
So there's no recommendation to do that for angiography. It is not, it's not the same as the risk with metformin, for instance, with ATN and risk of lactic acidosis with metformin, even though that risk is incredibly low as well. So there's no recommendation to hold it. If you do get ATN and you pick it up after someone's had dye, potentially the agent could be stopped later on. But again, the risk of any adverse effect, even with really low GFR, is so low that there's no need to preemptively hold it.
Okay, that's good to know. I know both you and Peter spoke a little bit about the diuretic effect of the SGLT2 inhibitors, which doesn't seem to be profound in most patients. In both of your experiences, are you adjusting your diuretic doses a priori, or are you just following up, 7 to 10 days later with other blood work, weight, etc., and then deciding whether or not you need to adjust your diuretic at that time? I personally do the latter, but I'm curious as to what both of you do.
Yeah. So if I can, just start, yeah, absolutely, yeah. And I tend to individualize because it's not always a predictable effect. Some patients, in fact, gets huge diuresis, maybe especially when their sugars are higher, and other patients, hardly have any effect. And but I think, Ellie, we kind of discussed this on Monday, during the nice rounds you held, is that if the patient's on the very dry side and is on a high dose diuretic, I may actually just temporarily cut that back, but I ask the patient to monitor themselves very, very carefully. And so the problem I had when I routinely was reducing diuretic earlier is that some of these patients end up actually coming back with fluid overload, because they got behind in terms of their fluid management.
I would just have to say I completely agree. I rarely adjust if someone looks like they're euvolemic. The rare situation where someone is on multiple agents, they're on Entresto, they're on high dose diuretics, and their blood pressure systolic is 80. That's when I'm sending that message to the cardiologist and saying, how would you feel about adjusting one of these medications? Because I really want to introduce an SGLT2, and oftentimes, it's worked out really well to collaborate together, and I kind of rely on you guys to tell me which one to cut back.
Yes.
Yeah, that sounds good. And we have one final question, which is practical but highly relevant. So for the patient that is under 65, so is not going to have and does not have drug coverage, what is the average cost of the SGLT2 inhibitors?
Yeah, so that's a good question. So, it works out to be about $2 to $3 per day. So, it's not cheap. GLP-1s are more expensive. So, a monthly prescription for a GLP-1 is $300 to $400. So yeah, so SGLT2s, lots of samples. Companies are great to provide samples, especially to specialty clinics. And then with the GLP-1s, they do also have cards, sample cards that the pharmacies also have that can help out with people who are financially unable to afford it. But it's obviously not always a long-term solution.
Okay, that's great. That's good to know, because now we have this armamentarium of medical therapies for our patients, and it's becoming more costly by the week. So, so that's good to know. So that's all the questions. We're at the end of the hour. I want to thank both Amel and Peter for their excellent presentation this morning. This was very beneficial, and hopefully we'll start to see a greater uptake of these therapies in the upcoming months. Just a reminder, next week we have rounds. One of our residents is presenting, Saad Al-Hassani. He's going to be presenting on LV thrombus. So have a good day, everyone, and thank you for joining us for rounds this morning. And thanks to Doctors Arnaout and Lou.
Thank you.
Thank you so much, everyone. Thanks, Amel. Thanks, Peter.
Thank you.
Thanks, Ellie.
Thanks, Amel. Take care.
Thanks, everybody.